Good evening and welcome to the Iridex Corporation webinar, The Role of MicroPulse Transscleral Cyclophotocoagulation for Your Glaucoma Patients. My name is Kevin LaMarche and I am the Director of Clinical Education at Iridex. Tonight we will cover the basic science and technique of MicroPulse Transscleral Cyclophotocoagulation and the Cyclo G6 Laser platform, and we will examine a number of patient case presentations who have undergone MicroPulse procedures. We are very grateful to have Dr. Brian Jerkins on the webinar tonight to share his experience and expertise with MicroPulse Transscleral Cyclophotocoagulation. Dr. Jerkins joins us from the Hamilton Eye Institute at the University of Tennessee, where he is Assistant Professor of Ophthalmology and Assistant Resident Program Director. Once we have completed the presentations, we will be taking questions from the participants. They must send via the chat application within the Zoom desktop. Now, let's get started. So the Iridex Cyclo G6 Laser platform is an 810 nanometer diode laser. It treats with thermal laser coagulative effects with tissue necrosis, and it operates in two different treatment modes. Continuous wave mode, which utilizes our G-probe and G-probe illuminate delivery devices, and MicroPulse mode, which utilizes our MP3 delivery device. In continuous wave, we have a expanding insult that continually expands based on the duration and the power that you dial into the Cyclo G6. The difference between that and MicroPulse is in MicroPulse, we introduce a very small thermal relaxation period, which allows for a short duration of tissue cooling as opposed to the exponential heat dispersion that you get with continuous wave mode. This allows for 85 to 90% of the efficacy that we see with continuous wave treatments, but at a much lower complication rate. The target tissue for both of these treatment parameters is melanin or pigment within the tissue itself. The melanin particles will heat up and then transfer, like a radiator, that energy to the tissues that are adjacent to it and continue on for the duration of the treatment. It's important to also know that there are other chromophores that will absorb 810 nanometer diode laser energy. Oxygenated and unoxygenated hemoglobin are two of them, and if you do have a subconjunctival hemorrhage or very tortuous conjunctival vessels when you go to treat with this laser, it's important to note that they will absorb some of that energy. And you want to make sure that you avoid those hemorrhages and that you can blanch those vessels so that all the energy desired is being delivered to the target tissue. If you choose to do transillumination using this to highlight the ciliary body so that you can treat directly over it, and you choose to use a marking pen, note, do not apply energy to the marking pen spot because that will mimic melanin and absorb that energy, and you could potentially introduce a scleral burn or a conjunctival burn by doing that. Take a quick look at light absorption by ocular tissue. On the visible spectrum that you can see here, the brown line represents melanin, the purple and red line oxygenated and unoxygenated hemoglobin, and the bluish line is water. And you can see that basically three of them have a coefficient factor of absorption greater than 1, with pigment being much higher than oxygenated and unoxygenated blood. It's just important to remember other chromophores will absorb this energy. Also, we have to apply basic photonics of light. We will get reflection, we will get absorption, and we will get transmission with this type of laser energy. And when you look at the tissues that we treat through, being the conjunctiva, sclera, and the ciliary body, you can understand why it is so important to have good tissue coupling to limit the reflection side of things and to move to the greatest amount of absorption possible within this tissue. Transscleral has basically the same mechanism of action, one to a greater extent than the other for both continuous and MicroPulse mode. It is a multifactorial effect. So we do heat up the tissue next to the ciliary epithelial cells of the ciliary body, which produce aqueous, and by absorbing that, we do have some restriction of aqueous production. We also increase the space with some shrinkage and some remodeling of the tissue in and around the superciliary space and sclera, which leads to some uveoscleral absorption enhancement. And by treating through the longitudinal muscles of the ciliary body, we actually see constriction and pulling all the way to scleral spur, and the spur itself histologically can be displaced up to about 0.5 to 1 millimeter. And in doing so, you add tension to the trabecular meshwork. So in effect, we can also get some trabecular resistance lowering effect to IOP as well. What we don't know is the combination of what percentage goes where, whether it's trabecular bypass, whether it's uveoscleral, or it is aqueous production reduction. We do know we touch all three of them. We just don't know to what percentage. Continuous wave mode has been around for 20 years, and we know that this is a valued treatment for end-stage glaucoma in basically blind and moderately seeing eyes, where we need to really focus on lowering the pressure to a great degree, as well as relieving pain. So here you will see more complications like inflammation, hypotony is a possibility, and even some more severe complications, where when we look at MicroPulse, that's where we really see kind of the benefits of a lower degree of complications, although it's still affecting those same three mechanisms of outcome, probably to a little bit lesser extent. The treatment delivery systems are different. Continuous wave, we do discrete single spot placements of the energy, whereas with MicroPulse, we're using more of a sweeping back and forth approach along the limbal margin. And it's with two different probes that we also deliver that energy. It's also very important to understand how the probe is designed for MicroPulse. There are some engineering perspectives that require things like a liquid interface and some pressure so that you can maintain excellent coupling. In effect, if you look at the picture of the probe, you can see that there is a small bubble fiber in the center. To make this bubble fiber, we need to burn and melt that fiber to create it. When we do that, we actually burn off the insulation and cladding that wraps the fiber and acts like a mirror to move the photons of light down the probe and fiber and into the tissue directly. So with that being removed, 45% of that light energy can now dissipate and be reflected sideways out the probe if you do not use a liquid interface. It's also the reason why we have pressure. Like a pen to paper, we need to apply some pressure with both the G probe and the MicroPulse probe to ensure that we have excellent tissue coupling and transfer of energy. This is just a small demonstration to really show the effects of using the liquid interface versus not using the liquid interface. We'll take the MicroPulse probe and we'll place it in a Petri dish that holds balanced salt solution with an envelope underneath as a target, and you can see how the beam profile will change when you're coupled with the tissue with that liquid interface as opposed to not coupled. And as the probe comes out of the liquid interface, you can actually see the scattering of that photons happen. Here we are out, moving into the liquid interface, and then back out. I'll play that one more time for you. Air coupled with the interface, then moving back out. It's quite dramatic. It's also very important, as I was talking about, to have laser tissue coupling. This is a contact laser delivery system. So being in contact with the tissue, being perpendicular and flush, meaning that we're not at any angle so that these photons can escape through scatter, is extremely important. The graph on the left-hand side shows the amount of reflection and then transmission and then absorption if you look at this laser system based on contact. And Here you have about 57, 58% reflection with about 32, 33% transmission. But interestingly enough, you're only getting about 7 to 8% absorption. It's why it's so important. If you do something wrong and you lose energy in the beginning of the procedure, it's going to dramatically affect exponentially the amount of energy that gets absorbed. The graph on the right-hand side shows you just the difference between firm pressure and gentle pressure in terms of the amount of coefficient factor absorption rate that you can produce. So with firm pressure, you're getting close to about 1.1x times the amount of energy being delivered versus gentle pressure. This is why coupling is so important with a contact laser delivery system. When we do the MicroPulse procedure, this is a very good picture to represent proper technique. Slightly off the limbus, you can see a little bit of sclera between the edge of the probe and the limbus. You're aiming towards the center of the eye or globe. That's your aiming point. The probe is flat and perpendicular as it can be to the tissue itself. And now sweeping back and forth in a methodical fashion, you're going to have a very efficacious and complication-free like procedure. These are the 9 points of the surgical technique as it stands right now. Number one, you must use a liquid interface. This is paramount and it's not optional. Two, the probe orientation. There is a flat side to the probe and a round side to the probe. The round side, which has a small notch on it, is facing the limbus, and the flat side is facing the lids. The reason for that, the flat side can also be used as a speculum, and the lid will kind of roll up on it, and that way you can have better exposure to the tissue as you're treating. The angle of the probe, aiming towards the center of the globe and perpendicular and flat to the tissue. Pressure, like pen to paper, we need to apply some pressure to get adequate coupling to ensure that all the energy desired is being delivered to the tissue that you want it to. From a technique point, you can treat hemispheres, so 6 clock hours at a time, or you can treat a quadrant approach. And the quadrant approach, it's a little bit easier probably to have exposure to 3 clock hours than to try to maintain it for 6. So we do recommend, especially when starting out, trying this way because you will have an easier time to concentrate on all the technique points as opposed to just trying to finish the treatment. Dwell time. Probably the single most important variable to doing this procedure is the amount of time per pass. So if you were doing 2,000 milliwatts at 40 seconds per quadrant, we would want you to be doing 4 to 5 passes. Okay, and that's actually a fairly slow dwell time, almost awkwardly slow. But when you think about how the procedure works, you need to give the tissue adequate time to heat up and transfer that energy. Otherwise, you're going to get a transient response as opposed to a permanent one. Power, 2,000 milliwatt is our standard procedure, and for a duration, either 80 seconds per hemisphere or 40 seconds per quadrant. And again, I think that there was a misconception that this was the end-all, be-all of treatment paradigms. It's not. It's a starting point for you. We tried to get you 85% of the way there for efficacy and safety, but it's very important to do a little bit of optimization and outcome analysis of the patients that you perform so that you can come up with the optimal treatment in your hands on your patients. It's very important, though, is if you do choose to change a variable, you only change one variable at a time. If you don't maintain those proper technique points, these are some of the things that can happen. If you don't use a liquid interface, it could result in the loss of up to about 50% of the energy. If the probe orientation is incorrect, it takes the fiber and it moves it much closer to the limbus, which means that you have the potential to treat iris root, corneal limbal cells, goblet cells, and part of the ciliary artery if you choose to treat over 3 and 9, which we do discourage. Position from the limbus, there again, giving an adequate amount of space so that that cloud of photons and energy is not being directed towards corneal tissue. Angle of the probe. If you're not aiming towards the center of the globe, then that energy could be then defrayed away from the ciliary body and into other tissues, and that could lead to a transient type response. Pressure. We want to have good coupling. If we're not coupled, we're not delivering the right amount of energy. When it comes to hemisphere or quadrants approach, they both work very well. It really comes down to what are you most comfortable with doing. If you get better exposure doing quadrants, then choose that. If you feel comfortable doing hemispheres, it's fine to do that as well. And then the last part, as I briefly mentioned, is optimization, doing outcome analysis, looking at your first 10 to 15 treatments and really seeing where did you end up with the duration of the treatment and how was your efficacy? Did it meet your target? If not, it is appropriate to then go ahead and maybe change either power or duration, but only one, and see what that equates to moving forward. If you gain the desired effect with your first treatments, there's no need to go through optimization, but you could have to do this to get the desired results. Now we're going to move to Dr. Jerkins and his case presentations of MicroPulse Transscleral Cyclophotocoagulation. Dr. Jerkins, it's all yours.
Okay. Thank you very much, Kevin. And I would like to thank everybody at Iridex for the opportunity to share some of my experience with the MicroPulse laser. I've been using the laser over the past 3 years. I've found it to be extremely successful in a multitude of cases. As mentioned, I am at the University of Tennessee Hamilton Eye Institute. I am a glaucoma specialist there, and what I'd like to share with you is just some of the instances of when I might use the MicroPulse laser. It's a little different than our traditional CPC. So when do I use it? Really, any glaucoma patient. It can be a patient with mild, moderate, or severe glaucoma, so there's no limitations there. Really, for me, it's whenever I need to advance treatment in any patient situation, whether it be a severe dry eye keratitis sicca patient who's having difficulty with medication or intolerant to some. It can be after an early glaucoma patient who's failed SLT. They could have had previous MIGS surgery, and you take your choice of which MIGS. It can still be used and utilized after any of them that are currently available. It could be a patient who's on maximal medical treatment on multiple drops. They could have had previous filtration or previous tube surgery. So really, any glaucoma patient that walks into your clinic nowadays could potentially be a MicroPulse patient and should be considered as part of your treatment options for them. So just to kind of utilize that, I want to take a look at a few cases and look at it from different types of patients that would walk into my office and some of the different roles that the MicroPulse can be utilized in. So this is the first case we're going to talk about here is a patient here that was referred into me with a history of cataract surgery in both eyes, severe keratitis sicca and dry eye in both eyes. Came to me with a history of severe glaucoma in the right eye, just mild in the left, and had already gone on some SLT in both eyes, but had a multitude of surgeries in the right eye. A failed trabeculectomy, already had an Ahmed valve placed that had already exposed twice. The Ahmed valve was subsequently had to be removed, and they've now had a second Ahmed placement in that right eye, and also had MP3 in the right eye after everything they've gone through, and still complained of a little bit of ocular irritation, but was compliant with their current medication. So this patient's been through a lot in one eye. Has medical history, just a little bit of hypertension, hyperlipidemia with the appropriate medicine for those conditions. Their ocular history, though, Tmax of 41 in their more severe eye, 28 in the left eye, a normal pachymetry and cataract surgery, as we mentioned. This patient's current medical regimen, though, due to their severe irritation, was a Ziopten in the left eye, Combigan twice a day in both eyes. The patient was very faithful with their Restasis and preservative-free artificial tears, and very intolerant to azopt and generic brimonidine. So when I'm seeing this patient, they're 20/50 in the right eye, which is the eye they've been through a lot through. It has an APD in that eye. Left eye's 20/20. Pressures that day, right eye was 11, but that left mild eye was 28. The conjunctiva in the right eye, thankfully their OMED was very well covered, but the left eye was just a little injected. They did have their dry eye with a thin tear film in both eyes. And the remainder of the eye was, anterior segment exam was really unremarkable. It did have a good surgical results in the right eye. And cup to disc, there was a little bit more cupping on the right of a 0.9 and 0.7 on the left. So this patient was running elevated pressure in their mild eye after having gone through a lot of options in their left eye. So we talked about what our options were, and we wanted to look at their testing. So testing here, looking at the patient's visual fields that day, right eye, as you would expect with severe glaucoma, does have some superior and inferior defects with the corresponding RNFL findings that are consistent with severe glaucoma. But that left eye with a pressure of 28 still looked pretty good. There was the cupping there, but fairly good neuroretinal rim, and also still a very full visual field. So this was a tough situation for the patient to be in, knowing that their good eyes now having problems. So we talked about it, and the patient did not want to go through any incisional surgery after everything they've been through in the left eye. And that included any potential MIGS options. So we talked about MicroPulse, and the patient decided to proceed. The MicroPulse treatment that I gave was 80-second duration. I do hemispheric treatments most of the time, and this patient got a treatment on the superior and inferior quadrant. I'm sorry, those were actually hemispheres, not quadrants. The patient's pre-op pressure, as we mentioned, was 28. I usually see my patients back. I do most of my surgeries on Wednesday, and I see them early back the next week. So at day 5, the pressure was 15, and that was on their same preoperative medicines. And at that point, I actually tapered them off their steroids and let them stop their Combigan. And at a month, the patient's pressure was already down to 11, and this is actually maintained very good over all the way up to the 6-month mark, pressure of 13 just on Zioptin in the left eye. So we've had over a 50% drop, as well as being able to decrease the medication. So it's been a very good result for the patient, and they avoided the possible course that they went through on their right eye. Second patient here is a little different, 76-year-old. He's got a history of ocular hypertension, but he's had a history of some progression on the OCT imaging from their baseline that was done about 3 years ago. This patient's very intolerant to medication in the past, and for that reason, they have had SLT in both eyes. The patient still does complain of some irritation as well as burning with the medication, but very compliant patient. This patient does have diabetes, some hypertension, has a history of a stroke in the past, but is well controlled on their appropriate diabetic medication, as well as still on a anticoagulant with their history of stroke. Tmax in the past was just above 30s with a little bit of a thin normal pachymetry. This patient has had cataract surgery in the distant past. This patient's current medication, Lumigan and Combigan in both eyes, again with Restasis and preservative-free artificial tears, so kind of another patient with ocular surface kind of issues. And not very infrequent to see in my clinic is a patient who has tried a lot of medications and having trouble with them. This patient has tried most everything that's out there, latanoprost, Travatan, dorzolamide, brimonidine, Combigan, and none of them are very comfortable to the patient. They are currently taking Combigan, but that's just to try to tolerate anything they can currently. So this patient is 20/25 in both eyes. Pressures though 25 in the right, 27 in the left. Exam really unremarkable anteriorly, except for some dryness and mild injection in both eyes, and some mild to moderate cupping of 0.55 in the right and 0.6 in the left. So this ocular hypertensive patient, as we would expect, does have thankfully good full visual fields and fairly normal OCT imaging here. So what do you do with this patient? So they're intolerant to some medicine on a prostaglandin and a combination, but not tolerating them well. Had SLT in the past, we talked about our options. We don't want to be running that high in the high 20s. So we talked about a repeat SLT, but rather than talk about incisional surgery, we opted for MicroPulse, which I thought was a great choice for this patient. Again, this patient had an 80-second duration of 2,000 milliwatt power, treatment both superiorly, and in this patient, I went ahead and gave 2 treatments inferiorly. Preoperative pressures, again, 25, 27. Post-op day 5, they're on their current preoperative medication. My standard protocol right now is I add Maxitrol 4 times a day for about a week and then taper. And at day 5, the pressures were not too impressive at day 5, but after tapering the steroid and allowing them to heal a little bit, by 1 month, the patient's already getting a nice significant drop in pressure down to 15 and 11. This stayed rather consistent up to month 6, and we were able to actually stop the comb again after the first month, and this patient's again been able to maintain pressures essentially in the mid to low teens in both eyes, just on Lumigan in the right eye and actually nothing in the left eye. So this patient's been very happy, and actually not only pressures are good, patients who don't tolerate good a lot of their medication, they really benefit from being able to stop some of their topical anti-glaucoma medicines. And so this patient is actually doing very, very well. Case 3, this is patients already undergone cataract surgery, and they did get a Cahoot blade as well as previous SLT in the past. Again, patient in this case is able to tolerate their medication, but due to age, this is an 81-year-old, they're starting to have a little bit of difficulty with forgetfulness, which is another issue with compliance in a lot of patients. The patients had a history of mini strokes in the past, some mild dementia, partly from that, and just their normal pathology, as well as some arthritis, which can also be a difficulty with some of their medication. Patient is currently on Aricept, but not much else except a multivitamin and some aspirin. They've had a Tmax pressure just above 30 in the right eye and around 28 in the left with normal pachymetries, and as mentioned, the surgery and lasers as before. Current ocular medication on Travatan and Ropressa as well as dorzolamide. This patient doesn't tolerate brimonidine and timolol, more for systemic reasons than ocular surface in this patient. So this brings up another type of class of patient where this might play a part. They exam that day, vision was 20/25 in the right eye, 20/20 in the left, so they've had cataract surgery, doing pretty well. Pressures, though, were elevated, 25 in the right eye, 23 in the left. The anterior segment exam in both eyes, really unremarkable, with some mild cupping, mild to moderate cupping in the right eye and the left eye at 0.65 and 0.7. So we looked at this 81-year-old's imaging, still doing really good for an 81-year-old with a history of glaucoma. Very good looking fields on the right eye, a little bit of early inferior arcuate on the left eye. And the OCT imaging does tend to correspond with the findings that we are getting both on my exam as well as on our visual field findings. So the patient does have glaucoma here, but for an 81-year-old doing fairly well, but pressure is still running a little bit high. So this brings up another option. This patient really didn't want to go under any more incisional surgery, and then I can't disagree with them at their age, but there is this concern that they may not be able to stick with the medicine, even if we were able to find them a good regimen. And this also would extend to postoperative medication. Just because we did a very good surgery, they may have difficulty with compliance for several weeks postoperatively. So we talked about MicroPulse as an option. The patient elected to proceed. Again, what I consider my standard, which is very similar to what Iridex recommends, of 80-second duration. I do the 2,000 milliwatt power. Again, this patient got 3 treatments, 1 superior and 2 inferior. I actually did both eyes about a week apart. Again, our preoperative pressures on travotan, ropressa, and dorzolamide of 25 and 23. At day 5, on the preoperative medication plus Maxitrol, we were already getting a small improvement in pressure. But where I really see the drops in pressures are usually several weeks later. So stop the postoperative medication with mild steroids. By 1 month, we're down to 13 and 12 in both eyes. I slowly take away medication. In this patient, we've been able to lower their drop regimen just to travotan at bedtime and having pressures of 13 and 14 at 6 months. And that's actually a big improvement both to their quality of life of only having to remember 1 drop, not to mention a very good drop in their pressure to maintain that good visual field that they have. The 4th case here, again, this patient's had a history of SLT. They've already had cataract surgery in the past, and they just do not like to take drops. Every time they put a drop in their eye, complains about burning and redness. And these are some of my favorite patients. It doesn't matter what they've tried, they don't like it. And probably for good reason that some of the topical medications have their own issues, but we've all had that patient who it doesn't matter what drop you give them, there's something wrong with it, or it's causing them a problem. So they've tried all of them. They've actually aggressively treated their dry eyes in the past. This patient had an SLT in the past, but really didn't like it and said that even that made her eyes feel really irritated and very light sensitive. Patient did have a history of fibromyalgia as well as hypertension. Currently on Lyrica, losartan, multivitamin, and they're doing everything for their dry eye. They've even tried fish oil, and that's not helping them that much. Their current, their T-max in the past was 36 in the right eye, 31 in the left eye. Thin, normal pachymetry, and the laser and surgery as mentioned above. Our current medication, though, just on Restasis and Refresh, a little bit of Pataday for some allergy and itching symptoms, but again, intolerant to Lumigan, Travatan, Timolol, and Brimonidine. So they just don't like medication. Ocular exam, 20/20 in the right eye, 20/20 in the left, but you just want this patient's pressure to be reasonable so you can almost not have to worry about them not being able to take medicine. But this patient's got a pressure of 36 and 31, pressures you just cannot ignore. Ocular exam is what you would expect with somebody with some dry eye issues, a little bit of injection and some inferior drying in a thin tear film. Cup to disc, 0.7 in the right, 0.6 in the left. So you do the visual field and OCT imaging. This patient now does have, with a pressure of 36 in the right eye, does have some early scattered defects on the right eye superiorly and inferiorly, and on the left eye there is a little bit of scattered depression inferiorly, and that doesn't look too bad. And then you look at the OCT, and there is some real thinning, a little bit more on the right than the left. So this is an eye that you just can't ignore at 36 and 31. So we talked about it, and the patient, as mentioned, did not like SLT in the past. And we talked about MP3 as a very viable option for the patient rather than considering any incisional surgery. And with their history of intolerant to medication and some of the sensitivity, I was not wild about talking about major in surgery on her in the first place. So we talked about MicroPulse as an option. Again, 80-second duration, 2,000 milliwatt power. Again, 3 treatments in this patient, 2 superior and 1 inferior. No medication to start off. I just treated them there kind of first 1 to 2 weeks. So at day 6, this patient came back. Pressure was 21 in the right eye, 18 in the left. And they've actually been able to maintain this pressure down in the upper teens at 18 and 17, 6 months out. Ideally would like to see them a little bit lower, but due to their intolerance of medication, this has been a good a good start in better controlling their pressure. So it was a great option in somebody who was just intolerant to just about any treatment that we've been able to give them to this date. So in summary, who is a glaucoma patient that is good for this? Really, any level of glaucoma patient can be considered a MicroPulse patient, whether they've failed previous surgeries or it is somebody who is just intolerant to any topical medication. It gives us a good alternative to treatment that has a good safety profile. It is very safe. It's very efficient, both from a procedure time as well as the amount of post-op visits. So you can do a MicroPulse very safely, very controlled, and very well in a short amount of time. And also post-operatively, a patient doesn't have to feel like they're coming back to your office every week. You can make the appropriate post-operative adjustments and see them back at a much more spread out interval than what something would be similar in the past. So this makes it a very limited and easier post-op course for both the patient and the doctor. And with that, I would like to thank Iridex for the opportunity for me to share some of my cases with you and some of my experience, and I'm welcome to discuss any questions and answer any concerns somebody might have regarding this treatment.
Well, thank you, Dr. Jerkins. That was very informative. We're now going to open up the question and answer series. So remember, using your chat function of the Zoom meeting, you can put forth any questions. We'll ask them and then discuss them. So we have our first question. When do you typically see the IOP affect the treatment in the postoperative period?
That is really one of my favorite questions to get, even from patients. I don't normally feel like I see the effect for several days, really up to more like a week to 2 weeks in my experience with it. And that's why I don't see a patient back on day one. I don't feel at day one I'm going to be seeing any results, and just don't make the patient come back. So really around 1 to 2 weeks is when I tend to see the biggest drop. And then it does tend to be consistently steady, and maybe even a little bit more drop over the next couple months. But that first 1 to 2 weeks is kind of the big first drop to me.
Very good. Question, what are your long-term results, say out 1 year to 2 years, and some of your MicroPulse patients, and what do you do if they fail late?
For these examples, I did only go out to 6 months. As mentioned, I've been doing this probably 3+ years at this point, and I'm still following many of those patients. I've not had many that respond, that tend to change course after they settle down after 5 to 6 months. So I feel like that is similar to me as maybe an SLT patient might be when they hit their kind of plateau for a little while. The patients that do fail or pressure starts to trend up over time, I do take that on a case-by-case basis. I have repeated MicroPulse before. I really don't like to repeat it quickly. I'm a little conservative. My general rule is I try to wait at least 6 months, but I have repeated it on a few people in the past. And I do take that on a case-by-case basis, but most of the time they do fantastic, and I just follow them as I would any other procedure.
Okay. Is there a particular reason that you use Maxitrol and not Pred Forte in your postoperative period?
In my case, no. Maxitrol is actually really easy for me to get for a lot of my patients here around Memphis, and I use the generic version, and that's just been my go-to and what I've been doing from the first time I've used it. I do use Pred Forte and Durezol in patients who have a history of uveitis. I will give them a little bit longer course, but there's no specific rhyme or reason other than ease of delivery and my patient's ability to acquire it.
Now, and so what would be your standard postoperative regimen then?
So right now, my current standard regimen is I give them, I continue on their current preoperative medication until I see them back, usually between 5 and 10 days. Most people are around 5 or 6 based on my schedule. I do give everybody, generally right now, Maxitrol 4 times a day until I see them back. I will usually at that point taper it off rather quickly. I may taper it off over a week or two. A few African Americans or history of uveitis, I may taper a little bit slower. And that's my current course. As I mentioned, I have used Durezol. I think I've utilized Lotemax a few times, but really more a case-by-case basis. But I just knee-jerk to Maxitrol right now. Again, more out of ease for me.
Okay. What kind of complications have you encountered, and have you ever seen any post-op CME in your practice?
I have seen transient CME, meaning I've seen it last post-operatively in one patient that I can recall. It lasted for a couple weeks, and there was a little mild hypotony initially with this patient, and they were very elderly. But this did resolve over the first month. Other complications, I've had a few people with already severe dry eye that do get a very difficult to treat dry eye after the surgery, whether that was more surgeon, in my case, getting too close to 3 and 9 o'clock. I've seen that. I've had 1 or 2 patients with a little bit of persistent iritis afterwards, but these are few and far between, and I've not seen any long-term complications that have not resolved.
So we've all had some thoughts and concerns over prostaglandin use and the potential for CME. When you recommend MicroPulse to your patient, do you do a macular OCT on everybody to try to weed out potential CME cases that maybe are subclinical or just have a small amount, you know, being an inflammatory treatment and potentially kind of stirring that up afterwards?
No, I don't routinely do an OCT, and it's a great point. Maybe I should be, but I currently am not. Just in the same way, if I treat somebody with a prostaglandin, I'm generally not doing a pre-op OCT, but I am looking for reasons that they might have it. So if it's a prostaglandin patient and they've had an open capsule or some other trauma in the past or edema in the past, yes, I'll be a little bit more conservative with that. I have done it on some patients with diabetic patients, certainly who've had neovascular and had a tube in the eye. And I find MicroPulse to be absolutely a great option after a failed tube. And a lot of these diabetic patients do have macular edema, and I've not really seen where it's adding a lot of macular edema. So it may be something that I should be more routinely doing OCT preoperatively, but I'm currently not. But if they are dropping vision afterwards, it is something that I will screen for more post-operatively.
Okay. What would be the longest follow-up that you have, or the longest patient out from MicroPulse so far in your practice?
In my practice, I probably have several that are 3+ years out at this point. I've been thankful to have lots of patients continue to follow me. So I have several that are probably 3 years out at this point.
And are they still, you know, well maintained? Have you had to retreat? You know, where are they sitting pretty much in their course of history?
Many of these patients are very stable. I tell a lot of patients it's still probably a lot of those 3 years ago were still kind of in my learning curve. And Kevin, as you mentioned, on actually some of the actual technique, that's probably the biggest thing that's made a change over the last year or two, is actual getting better at dwell time positioning, so that I don't feel like I have to retreat like I used to. When I first started out, I would actually tell people, okay, about 50% of the time we're going to get the pressure where we want, and then there's, you know, the other 50%, a significant amount of those are going to need potentially a second treatment. And then there's a small percentage, like many glaucoma procedures, where we just have to try something else. So I do think there was probably a fair amount in that first group when I was kind of in my learning curve of more how to do the technique that would have had some more treatments. But currently, I cannot remember the last time I had to retreat on a MicroPulse.
Okay. Do you take pigmentation into consideration as you're treating your patients? And I know that from a continuous wave treatment, there is a technique Dr. Gasterlin had basically spearheaded where they do look at iris color and they do try to equate that to pigmentation and make changes based on that in terms of power and duration. Do you take that into consideration with MicroPulse?
I do a little bit of decreasing the duration. I think I've decreased it on a few people that I was worried about that, but I have not been playing around with the power. And on the other side of that is the treatment time is probably the one variable that I'm playing with the most, because there are so many subtle things that are playing into the part. I'm working more on technique and adjusting my time. So for instance, if I'm concerned about a patient might not have a lot of other options, but we don't want to over-treat this patient potentially, I may only use seconds or I may only treat just the superior hemisphere. I'm trying to treat somebody and get a drop in pressure, but also this isn't somebody who needs an enormous drop in pressure, and I don't want to potentially cause a hypotony.
Okay. Have you used a G-probe and done continuous wave procedures, and how did you settle on MicroPulse as your procedure of choice?
I've done G-probes in the past. I don't think I've done one in the past 2 years, but I had utilized those a lot in the past. And as we're all traditionally taught and are used to doing it, that is more a end-stage glaucoma procedure, very high pressures, no other options, blind eye kind of treatment that frankly is, even when done correctly, does have some discomfort and some post-operative pain. And once I started doing MicroPulse and I compared them back and forth a little bit, the MicroPulse patients not only were doing great, but they were extremely tolerant of the procedure. And that's what sold me on, I'm getting great results. So even on the patients who I might traditionally do a G-probe on, I might as well still do a MicroPulse. I'm going to get great results, and it's not going to be a difficult course for the patient. I do most of mine under just a very light sedation, and I joke with my patients, 90% of them are going to wake up right after a little bit of sedation, and they always ask, when are we getting started? So it's a very pleasant, quick experience for the patient, and that's what's kind of tipped me over, is I'm getting predictable results, maybe even more predictable than a G-probe, minus the post-operative complications, and the patients just tolerate it extremely well. So I don't really do G-probe at all anymore.
Okay. Brian, interestingly enough, one of the next questions was about anesthesia and your anesthesia of choice, and I hear you mentioned mild sedation. Is there any reason why you're not doing a peribulbar or retrobulbar and you've chosen mild sedation? Are there risks or rewards with either or?
Well, the way I do it both ways. I would say more the standard way I do it is I do it in our ASC, usually quickly between some other patients while they're maybe setting up another room. I try to flip 2 rooms when I can. They would give generally a little mild dose of propofol if the patient's very healthy, and I'm literally sitting there talking to the patient while they're getting a small dose. As soon as they become, the anesthesia hits them, I generally preoperative before I do the MicroPulse, we'll do a small retrobulbar block, more for a little bit of proptosis for me, and well as a little bit of potential post-operative pain. And then I do my MicroPulse procedure very quickly while we're all there. And then I give them a little bit I put a patch on the eye for a couple hours, and that's it. that's the way I do it traditionally currently, but I have done it what I would call topically in many patients. Maybe they're not a great anesthesia patient, or they have various reasons why we need to do it now. I've done it in clinic several times, just under topical sedation, but or I'd say topical and subconj sedation, but it takes a little bit of time. It's the patient who I systematically numb up over about 30 minutes and then kind of cherry pick their ability to tolerate a little bit of pressure on their eye for a few minutes. So I think it is a topical procedure if you have a good patient, but a little bit of mild sedation makes it just extremely easy for them.
If I could just add that if you are going to choose to do peribulbar or retrobulbar anesthesia, I think it's important, because I notice doctors finishing the anesthesia and then wanting to treat right away. And it takes 15, 20 minutes for that anesthesia to take. So if you deliver it and then try to treat right after, you're going to have a very uncomfortable patient. So it's important to give them the time for that anesthesia to take prior to you trying to deliver the energy.
Oh, I completely understand. Thankfully, the anesthesia doctors I've got right now, they actually do a pretty good job. So by the time their anesthesia wears off, we are done. And it's just the little dance that we've developed. But we've got a little system down, and yes, occasionally somebody might wake up a little bit, but right now we have it where they'll keep them. If I'm ready to do the procedure, we can do it all in a good 5 to 10 minutes very safely, and the patient doesn't feel a thing.
Excellent. The next question is concerning cycloplegia. So do you cycloplege your MicroPulse patients, and vice versa? Would you also cycloplege your continuous wave patients?
I actually don't do any cycloplegia on any of my patients for this.
Okay, very good. I know that historically for continuous wave, there was the use of cycloplegia to help them. So, but I agree, for MicroPulse, I have not seen people cycloplege.
Correct.
Okay, in terms of any severe types of complications, have you experienced any vitreous hemorrhaging, any cryptid visual acuity loss, persistent inflammation in the anterior chamber, or experienced any formation of cataracts in conjunction with MicroPulse?
I wouldn't say I've seen any major complications. No vitreous hemorrhage, no significant corneal problems other than 1 or 2 dry eye patients that had a persistent dry eye. I've had 1 or 2 patients with some rebound iritis that has taken a little bit of time to clear, but other than that, no other significant complications. If there has been a progression on a cataract, I have not really appreciated it, and I don't think it's been significant if it has. But otherwise, no posterior complications whatsoever. No, like I mentioned earlier, I've not had a problem with any significant CME long term. So it's been relatively complication free.
Have you experienced any hypotony at all with the procedure?
I have had 1 or 2. There's one lady that I know she was hypotenuse for a good 4 to 6 weeks afterwards. That's since resolved, and might put an asterisk with that. This was a patient who had already had a previous tube, just did not tolerate any medication. And they were a little elderly, so. And that was a case I may have overtreated them a little bit, but it's since resolved after about 5 to 6 weeks. I've not had a patient with persistent hypotony with this, and that's not something I could say in the past with G probes. Even with patients who had significantly high pressures, there was the instances and a real concern that you could get a hypotenuse patient. And I've just not had that with MicroPulse in a long term.
Do you avoid the 3 and 9 o'clock meridians when you treat?
I really try to. I think that still is the one thing that is very much a concern with this, and it's very easy in some patients to almost lose your landmarks a little bit. So I do try to avoid 3 and 9 o'clock as much as possible.
Have you used any subconjunctival steroids as a postoperative regimen as opposed to drops or in combination with drops?
I really haven't with this at all. And it is something I do probably about half the time on my glaucoma surgeries. I will use subconj injections. I've not used it one time that I can remember with a MicroPulse. I may have once or twice in the past with a G probe, but that was not something I utilized on a regular basis.
So I know that at AGS this year, 2019, there was a poster concerning transient mydriasis. Have you experienced this phenomenon or complication in any of your patients?
I would say I probably have. I do think some people do have a little bit of transient mydriasis, and just like you get a patient with some rebound inflammation. So I do think you're treating a significant amount of uveal tissue there, that you are getting some transient mydriasis, but I haven't seen it be clinically significant or anything that's been long-term.
Okay. And if anybody's interested, the poster was by Dr. Sean Lin of UCSF in San Francisco, and it was presented at the AGS meeting this year, 2019, if you want to look it up. How about phakic patients? Are you comfortable treating phakic patients, and have you done any combination cataract with MicroPulse procedures?
I am comfortable using it with phakic patients because, like I mentioned earlier, I really haven't seen it cause a progression of cataract, and it's really, for the most part, very minimally inflammatory. So I think it is safe to use it in most cataract patients. I've not used it in combination with phaco, although I've used it in combination with some other glaucoma procedures. I've used it in combination with a hook blade before, and I've used it several times in combination with tube shunt placement. And had no major problems with either case.
Two-part question. Number one, do you treat uveitic glaucoma patients with MicroPulse? And two, do you have any experience with congenital glaucoma and MicroPulse?
I've treated 1 or 2 mild uveitic patients with MicroPulse, and these were patients who had already had previous tube shunts. That is still a subset of glaucoma that I'm really cautious of with anything inflammatory. But if they've had a previous tube shunt and they're actually fairly well controlled, I have used it in those instances. With congenital glaucoma, I have not had any significant experience in that setting at all with MicroPulse yet.
Okay. Have you noticed any patients requiring a trabeculectomy after MicroPulse? And how does it affect the outcome of the bleb due to treating with MicroPulse through the conjunctiva?
I've done several trabeculectomies from people who've had previous MicroPulse. Not many of them. I've had some that have had MicroPulse elsewhere, and maybe 1 or 2 of my patients have. And I've done some actual tube shunts as well that have had previous MicroPulse. With the conjunctiva, I would say in some patients it does tend to be a little bit more scarring near the limbus, but not anything that's significant in my experience. I think some of them in the previous with G probes was a little bit more concerned for some conj scarring, but it's something to be aware of. The conj itself being friable, I don't see that as a difficulty, but some of the limbal conj in a few instances can be a little bit harder to initially mobilize.
Well, here's another somewhat related question. Is it okay to pass the probe in standard fashion over thin or ischemic conjunctiva, especially from a previous filtering or tube shunt procedure, or should this area be avoided?
I think if it's vascular and you're very careful with the probe, it can be done. Careful meaning when we're looking at the physics of it, there is that little bit of a exposed edge of the needle, or not, or edge of the actually the laser itself, right at the tip of the probe, that you want to be careful. If you push down and pull it the wrong direction, you can get a little conj tear, and over thin tissue, I'd want to be careful. But if it's vascular, I will still treat over that area very lightly. If it's an avascular area, say they have a previous avascular bleb, or very, very thin conj over a tube, I still avoid that area. So there will be some patients that I may avoid a clock hour or two completely, just to avoid any risk of complications.
Okay. Have you ever seen patients develop significantly slow to clear SPK post MicroPulse? And could this be an effect to the corneal nerves, the limbal stem, or another mechanism? And are there any good techniques to minimize this effect?
Yeah, I think this is definitely one thing that I have to work on and am conscious of when I do these surgeries. And a lot of these patients that I try to do the surgery on are already patients who have dry eye issues. But I think this is a big technique of making sure you do give a little bit of lip between the limbus and the probe, and definitely avoid 3 and 9 o'clock, because if you do get close to 3 and 9 o'clock, or you're hugging the limbus a little bit, I think SPK can be an issue. The stem cell thought is a great idea. I can't say yes or no to that. I've always felt it was more due to getting a little bit close to 3 and 9 o'clock. And in my instance, or a patient who maybe I got a little bit too closer to the cornea during the procedure. But the dry eye is something in some patients that does take a little bit of time to clear. And again, it's patients who were really dry in many instances going into it. So it's hard to tell whether it's procedure or just the patient themselves.
You know, I think the tough part here for surgeons is, you know, these eyes have been, you know, for less than a better term, marinating in, you know, a number of pharmaceutical agents to lower the IOP for so long with all these vehicles and preservatives. It's hard not to get a patient in glaucoma that doesn't have some dry eye, you know, exposure or some ocular surface disease. And then on top of it, you've got a technology that's delivering energy that if you aim it towards the limbus, you are treating stem cells and goblet cells and ciliary arteries. So it's difficult to maintain that proper technique to ensure that you don't enhance those dry eye symptoms. So it's really a big call out to make sure that the technique is maintained, that you're staying off the limbus, that the angle is appropriate and aiming towards the center of the globe, and that the orientation of the probe is proper so that that fiber is moved away from the cornea as opposed to closer to it. Okay, that was our last question, and we're at about an hour now, so I just want to say thank you for joining us this evening, and my biggest thanks to Dr. Jerkins and his time for helping us understand MicroPulse and its role with your glaucoma patients. The recording of this webinar will be on the Iridex website under Physician Resources and should be available within the next week. So we thank you very much, and please join us for our next webinar, which probably will be in a month. Good night now.
Thank you.